Everyone, today we're going to look at some psychotherapeutic drugs. We're really going to cover mostly first generation and second generation antipsychotics. And we can't talk about those without talking about schizophrenia. So let's get into it. So schizophrenia, we know is going to be both in men and women. In men, it's going to happen on more earlier, so that's going to be really in their adolescence up to age around 25. Women might actually have onset a little bit later, around 25 to 35. Now, in general, what's happening with these patients is they have a different degree of effects. We have them in here. We have positive symptoms, negative, and cognitive. So positive symptoms are really what people think of schizophrenia, right? They have these delusions, whether they're auditory or visual. These people think they're hearing things, or sometimes they're telling them to do things. Negative symptoms are diminished expression. So that means they have less facial expression, they have less involvement or talking and stuff like that. How I kind of differentiate these are positive symptoms are like their central nervous system is like hyped up, like it's really working hard. Negative symptoms less, like it's actually diminished. So you get less of like, these delusions and stuff. You get more of like kind of this mass-like phase hypotonia in general. They're just like not really interested. Cognitive impairments we might see later. So that's issues with memory or attention and stuff like that. Objectively, when we're interviewing these patients, according to DSM-5, you need to have 2 or more of either positive symptoms or negative symptoms to be able to make this diagnosis. We know there's a ton of other things that might cause people to have these kind of things like delirium, side effects of medications, stuff like that. So keep your diagnostic differentials large here as well. But what we do know, possibility, is there's a lot of anatomical changes with these patients, maybe involving the amygdala, the hippocampus, the lateral ventricles. But we also see maybe that they actually have too much dopamine in the body. Now, that's not the only reason, but that's something that we found that if we treat that with pharmaceutical agents and stuff, we can actually help these patients out. So let's talk about that. So we know in schizophrenia that maybe there's too much dopamine in the body. Therefore, what we give is these dopamine receptor blockers, which we now call first generation antipsychotics, second generation antipsychotics, or atypical antipsychotics. So they're going to block the effects of dopamine, and we've seen that that does help these patients. Well, let's go through these. So we have both first generation and second generation antipsychotics, and we're really going to cover the big side effects. So first generation antipsychotics like chlorpromazine and Haldol. Now, these are also kind of divided in their potency levels. So an example of a high potency could be like Haldol. The more potent they are, the more likely they might be to see some of these side effects. So the first biggest side effects are these extrapyramidal movements. So remember, when you look at the medulla, in the medulla oblongata, we have the pyramid. Well, things going through the pyramid are the cortical spinal tract and our cortical bulbar tract, right? So that's big for movements and our cranial nerves, stuff like that. Extrapyramidal, outside of that pyramid, are going to be things like that help our tone, our posture, involuntary movements, all those things. So what they think is when we block dopamine effects and we have less dopamine readily available, it might cause these side effects. So one of the first ones you can see is acute dystonia, which is one we see kind of early on, maybe hours to days after starting the med. We can see spasm of the face, upward deviation of the eyes, and even issues with talking. Now, sometimes these people can kind of come in more like an acute reaction or a crisis, and the treatment we're usually going to give them is an anticholinergic like Benadryl. The next one is Parkinsonism. If you remember my lecture on Parkinson's is usually caused by lack of dopamine, right? We don't have a lot of dopamine. Therefore, we get these symptoms of Parkinson's, which we call Parkinsonism, and what I use is mnemonic trap. T, right, is going to be for our patients that have, they're lacking their tone or they have this resting tremor, okay? So I kind of always tell people that. They have this resting tremor, maybe their tone is off. R is going to be for rigidity. We know they're very rigid. A is going to be akathisia or bradykathisia, so they have issues making a movement happen, no movements or slow movements. And P is for postural autonomic issues, so we know they like to bend forward, they have the shuffling of the gait, they might have issues with their bowel, their bladder, stuff like that. But in general, Parkinsonism symptoms can also be caused by these drugs, because Parkinson's in general is going to be the extrapyramidal again that's causing these issues. So when we're looking at these patients, we want to watch them. It's also very important to remember Parkinson's and schizophrenia is like polar opposite, right? Schizophrenia is caused by too much dopamine, we think, so we block dopamine with first and second generation antipsychotics. Parkinson is caused by not enough dopamine, so we give them levodopa, carbidopa, which increase our dopamine levels. Well, the idea here here is for the extrapyramidal side effects, we can probably give both of these guys a dopamine agonist like amantadine. We know can help out with that as well. We know our dopamine agonists are going to be things like amantadine, amantadine, Pramipexole, Requip, stuff like that. So those are dopamine agonists that we think might help out. Next is going to be akathisia, which is not to be mixed up with akinesia that we see in Parkinson's disease when we're using that mnemonic trap. So akathisia is like opposite of akinesia, where they just can't stop moving. They have restlessness and they just want to move. Sometimes we can give them benzos or just decrease the dose. Last but not least, common one we see sometimes untreatable, tardive dyskinesia. So a lot of different things happening here, guys. They can do, I kind of have to just show some of these things. So things with their tongue, like pushing down their tongue, pushing down their cheeks. They can have kind of the frog tongue, where they go. It's like a tongue. It's almost like a frog going for a fly. They can have kind of licking their lips, lip smacking. They can have slow chewing. Okay, amongst a lot of other things here as well. So with this one, they can sometimes even come in acutely, but here's the interesting thing about tardive dyskinesia is what we normally do is we increase our dosage of a first generation antipsychotic because we think, okay, we'll block more. That actually does help at first. But what we think is it's not so much caused by the amount of dopamine. It's actually the receptors are starved of that dopamine, so they become hypersensitive. So even though we can increase the dose, less dopamine, those side effects will go away, they actually come back. Because it's not so much the dopamine. It's the receptors themselves. We're just keeping up their sensitivity. So we need to really watch these and try our best to help these patients with these side effects. Other things we can see is neuroleptic malignant syndrome, which what we can see is lead pipe rigidity, hyperthermia, issues with their consciousness, and stuff like that. Want to watch that. Sometimes give benzos, cool them down, and take away this first generation antipsychotic. Outside of that, sexual dysfunction, very common to see with a lot of our psych meds that we'll be covering. We can also see neuroendocrine issues like increased prolactin levels, which in women can cause issues with their breasts, but also cause maybe abnormal uterine bleeding, or just in general cause issues with ovulation in general. Other things we can see here, agranulocytosis, a lot of times, especially with our psych meds that start in C, get a CBC, right? So we know they can have decreased white blood cell count, decreased neutrophil count, obviously, so increased risk for infection. And then dysrhythmias. So anytime we give, like Haldol is a good example, we always want to check their QT because it can cause QT prolongation. Second generation antipsychotics are a little bit different. We call these atypical antipsychotics. So this can be like Zyprexa, Risperidone. Who else do I have here? Clozapine and Seroquel. So all these guys, not only do they block dopamine, but they're also going to block things like acetylcholine, histamine 1, serotonin. So the good thing about them is they block actually less dopamine. So these guys have less effects of their extrapyramidal side effects. But it doesn't mean they don't come out with other side effects. So really what I say is a lot of these side effects we see with our first generation happen with second generation. But the big one we always are, that's most cumbersome, this extrapyramidal side effects, are less in our atypical or second generation antipsychotics. The only caveat to that is a lot of times what we can see with these patients in second generation atypical, is going to be metabolic syndrome. So they can have increased weight gain, they can have increased lipid levels, and they can have new onset diabetes from starting our second generation, being our Seroquel, Clozapine, Zyprexa, and Risperidone. In general, guys, I want to make this very clear. I talked about dementia, and one of the most common causes can be Alzheimer's, and I talked about later in Alzheimer's, about 80% of those patients can get psychotic issues like agitation, anxiety, all those things. We want to be very careful treating them with the first or second generation antipsychotic, as it may increase their risk of death. Just keep that in mind. Hope you guys like that. We got more coming on psych meds, so stay tuned. We'll see you.